Mike, for our sort of last comment, I know you've spent a lot of your career looking at combination immunotherapy, vaccines, and other approaches. Do you see that those techniques might, in fact, expand the number of patients in colorectal cancer who respond to immunotherapy?
Yeah, well, obviously a huge open question, a lot of research going on in the area. I think we need to, as we understand more about the molecular subtypes of colon cancer and where there might be an effect, so if you take what we talk about as the CMS4 group, they have a immunosuppressed environment. There may be a role for trying to change that immunosuppression. The CMS2 and 3 group, it's an immune desert, so we're going to have to find some strategies to get the T cells actually to the tumor so we can modulate them with checkpoint. And I mean, we could have a totally, you and I could have a totally different conversation about this, about all the different strategies being done to try to achieve that.
But we probably, I know, Tony, you feel strongly about this, we probably will still be left with some patients where immune therapy is just not going to do the trick.
I mean, if you have a tumor that's, let's use the simple terms, incredibly cold, nothing is going to make it hot, at least with the tools we have today. The warmish, warmer tumors, you probably would benefit more. And in fact, you know, we know that strategies that have not selected so far, and we have a couple of very negative abstracts that are in the back of the proceedings, and we have a large study, Emblaze, that also was negative. Not selecting the right patient with a reasonable strategy will end up essentially, you know, negative after negative.
But there's obviously going to be excitement. You already brought this up about the nivolumab, regorafenib.
Sure.
You know, we have to see where that goes.
And this is where again I would argue that it's exciting, but it's still limited to a small percent of patients. And at the end of the day, and even if it's 20-30%, and that translates into 10% when you go to a phase 3 study or 15%, those patients benefit. How can we figure out who are those patients that we're going to actually focus on and then leave the really cold tumors for a different strategy?
Just like really cold tumors at my age, nothing is going to make me hot either.
You are one hot tamale.
Gang, you guys are great. This has been an amazing discussion and really informative. I hope you out there feel the same way. But before we end our overall discussion, I'd like to open the floor and give each one of you a chance to give your final thoughts on this. Kathy, you get to go first. What's your overall thoughts about colorectal cancer today?
I would just, based upon all the information we discussed here, obviously there's so many things we still don't have a definitive answer for, so we still need to encourage patients to participate in clinical trials.
And do we have clinical trials for them to participate in?
There's several clinical trials all across the board, but we need the patients.
We need trials too. Tony?
I think the most important thing that, you know, we need to keep on reminding our physicians that care for patients with colon cancer is we really need to have that genetic information from day one, if possible, at least at minimum the ones we discussed, BRAF, RAS, HER2, MSI, maybe NTRK fusions and others, but perhaps an expanded. And we have to do these reflexively because they do affect not only how we decide to treat our patients, but also access to clinical trials.
Dr. Dustin Denning.
So I think what's really exciting now is that what we're seeing is the more we understand about the biology of colon cancer, the better we're able to actually develop more personalized treatment options for patients, whether that be immune therapies or targeted therapies. And so I'm really excited as we're learning more and more about the biology that will continue to advance the field for patients.
Yeah, thanks. And Michael, you get the last word.
Well, I have to say that immunotherapy does have a role in colon cancer, of course, and I am hopeful that it will have a role even in microsatellite stable. We didn't talk about the role of the microbiome, and I think as we understand not just the biology of the tumor, but the host's response and the host's environment, environmental factors, and so on. I think it'll change our understanding of how to manage the disease.
Eat more dirt, fix your microbiome.
Yes.
That's the secret. So thank you guys for your contributions to this discussion. And on behalf of our panel, we thank you for joining us. We hope you found this peer exchange discussion to be useful and informative.